Hello, and welcome to another live broadcast with MedStar Georgetown University Hospital. My name is Karen Zingle, and I'm joined today by three of our gastroenterologists, our GI experts, who will be discussing colon cancer prevention, including the signs and symptoms, who is at risk, what measures to take to prevent colon cancer, including genetic counseling, and how screenings can help. So let's welcome our experts. We have Dr. Priyanka Kant, Dr. Angelica Nocerino, and Dr. Joseph Jennings. Thank you for joining us today. Let's get to know our experts. We'll have you introduce yourselves to our viewers. Let's start with Dr. Nocerino.
Hi, everyone. My name is Angelica Nocerino. I'm a gastroenterologist at MedStar Georgetown and MedStar Lafayette. In addition to general gastroenterology and colon cancer screening, I focus on motility disorders, such as issues with trouble swallowing, GERD, pelvic floor issues such as constipation, fecal incontinence. I really love being a gastroenterologist. It's a very fun and rewarding field. And through all the testing, procedures, and treatment options we have, you can really have a tangible effect on patients' lives and improve their quality of life.
Wonderful. Thank you so much. Dr. Kant, will you introduce yourself?
Awesome. Thank you for having me here. My name is Priyanka Kant. I'm one of the gastroenterologists here, and I focus on GI cancer prevention. So that is my area, my clinical and research in this area, including the genetics, what can increase their risk. And I see a lot of patients. I have a dedicated space for patients who may have a genetic condition that increases the risk of GI cancer. I call it GI cancer. It goes beyond colon. So I say it's a full GI cancer prevention clinic, including some research and other efforts, very collaborative. So I'm very excited to be part of this today. This is what I do. And thank you for having me.
Of course. Thank you. And Dr. Jennings,
Yes,
introduce yourself.
I'm Joe Jennings. I am another gastroenterologist located at MedStar Georgetown, as well as our Lafayette Surgery Center and our office in McLean. Like Dr. Nocerino and Dr. Kant, I also work with patients to identify early signs of colon cancer, prevent colon cancer, diagnose colon cancer. But my specialty research is in bleeding of the GI tract. So I also deal with a lot of patients who have issues with constant chronic bleeds from the GI tract. And I'm also one of the associate program directors for our training program here for our GI fellowship here at Georgetown.
Wonderful. Well, thank you all again for being here. And thank you to our viewers for joining us. If you'd like to learn more about colon cancer prevention, then stick around, share this broadcast with your friends, give us a like, let us know you're watching. And if you have questions for our experts, you can ask them in the comments below. So we're going to get started with the discussion. I have a few questions just to get us going with the discussion today. And these questions are for you, Dr. Nocerino. Let's start with just the basics. What is colon cancer? And can you talk about whether or not it is preventable?
Yeah, so colon cancer is a cancer that affects the large intestine, also known as the colon and the rectum. It is actually thought that a large portion of colorectal cancers and deaths are thought to be preventable. So with colonoscopy and colon cancer screening, precancerous growths in the colon and rectum, known as polyps, can be detected and removed, potentially preventing the progression or growth to colon cancer. In addition to colon cancer screening, things such as exercise, healthy eating, and maintaining a healthy weight can reduce your risk of colorectal cancer. But some people, even if they're maintaining optimal diet and lifestyle, may have a genetic risk for colon cancer and still develop it. And we'll talk more about that later.
All right, thank you. So who is at risk for developing colon cancer?
Yeah, so as I previously mentioned, people with a genetic predisposition are at increased risk. So that may be a personal family history of colon cancer or high-risk polyps, whether that be in a first-degree relative such as a parent or a sibling. There are also genetic syndromes that predispose to developing colon cancer, such as Lynch syndrome. Even those with inflammatory bowel disease may be at increased risk. And the thought behind that is that if there's uncontrolled chronic inflammation in the colon, that may predispose to development of cancer. Additionally, there may be lifestyle factors that play a role, such as lack of regular physical activity, a diet low in fruits and vegetables, a diet that's high in processed meats, high and extensive alcohol consumption and tobacco use may also be factors that can put you at risk for developing colon cancer.
Okay, thank you very much. What are the signs and symptoms of colon cancer?
So colon cancer may not actually cause any symptoms at first, and that's why we recommend doing screening and colonoscopies even if you don't have symptoms. As the cancer grows in the colon, it may start to cause some symptoms. It may cause blockage of the passage of stool, which can result in symptoms such as extreme abdominal pain, changes in bowel movements. So people may describe feeling more constipated. The number of bowel movements they typically have in a day may change, as well as the texture of the stool. So they may describe thinner stools, and of course, blood in the stool. So if you ever see blood in your stool, it's always important to discuss this with your gastroenterologist.
Okay, and that's a good segue for Dr. Jennings. I have a question for you.
Mhm.
When should, so if you have blood in your stool, is one example that Dr. Serino mentioned, when should you go see a gastroenterologist?
So that is the main question here, and it brings us to like a difference in the terms, right? Because a lot of what Dr. Nocerino was mentioning before symptoms is when we talk about screening, right? So screening really means in the absence of symptoms, but when you have symptoms, the sooner they get evaluated, the sooner we can determine that is any further testing needed, is there something else we need to do? Because not all symptoms are definitively signs of colon cancer. As Dr. Nocerino mentioned, a lot of those symptoms are caused by a lot of things. And thankfully, a lot of them are not dangerous. So blood in the stool can range from, I have a hemorrhoid, right? A vein that's dilated down there that was irritated and bled a little bit, or it can be a sign of something growing inside the colon that's not supposed to be there. So the sooner when you recognize a symptom like blood in the stool that you go and talk to your doctor or your doctor sends you to talk to a gastroenterologist, the sooner we can help you differentiate based on the history itself, but more importantly, by looking and figuring out what the actual diagnosis is, we can help you determine which test is best to figure out where that symptom came from. So usually if you see blood in your stool, talking with your doctor sometime in the next couple of weeks is recommended. So that way we can get things started, get that timeline moving forward on when we can investigate those symptoms.
All right, thank you very much. We talked a little bit about prevention. Can you reiterate or expand on what we talked about earlier in terms of prevention? How can, if someone's thinking right now, how can I prevent colon cancer?
Yeah, and so the biggest thing we can do in prevention is screening. So when we don't wait for a polyp or cancer to grow to the size or grow in a certain spot where it actually produces symptoms, we can then intervene on that far earlier when we find it earlier because we are being proactive as opposed to reactive. So the best preventative tool we have is screening. And so colon cancer is somewhat unique in that the precancerous lesions, we know a lot about, and we have a tool that can easily go find them and remove them without, things like surgery for the majority of patients. So, by going and looking when there's not symptoms, finding those polyps when they're really small and really easy to remove with colonoscopy, I can then prevent that polyp from ever having the opportunity to turn into colon cancer. And I think the thing to remember about colon cancer, and we'll talk about the groups who are at considerable higher risk relative to the average population, is that the average person's risk for colon cancer is still pretty noticeable. It's a relatively common cancer, right? Depending on which studies you look at, it's anywhere between the third or the fourth most common cancer in the country. So all of us, by the nature of living longer, which is wonderful, and experiencing more time, give polyps more time to grow, give those polyps more time to potentially turn into colon cancer. So by living and having time, we have a chance of developing polyps. And so that's why we recommend don't wait for a symptom, depending on your family history and your exact story. Let's start screening when we can look and find these things much earlier. Other things have all been, the data on them is a little bit different. So things like, high fiber diet, less processed meats, red meats, healthy diet, exercise, all those are great things and they have other benefits. And they probably do carry some benefit to reducing your risk for colorectal cancer. But the risk factor of time being as universal as it is, even those people who are on a perfect diet, who have a perfect weight, you are an Olympic athlete who's done everything right when it comes to diet and nutrition, you still need to be screened with some tests, right? So nothing that we do from those other factors is enough to be like, well, since I'm taking care of my diet so well, maybe I don't need to talk about colon cancer screening, or maybe I don't need that colonoscopy or stool test or the other options we have. We all need those. There might be some things that we can do to make it so that way I'm much less likely to get a positive test. I'm much less likely to need my colonoscopy as often as someone else, but we still need to screen even when we do all the other stuff completely right.
Thank you. And I know we'll talk more about screening a little bit later, but I want to expand on what you mentioned about the Olympic athlete that does everything right, that has no family history, no symptoms. When should they be getting a screening? Is there a specific age?
Yeah. So average risk, what we call average risk, and we're talking about screening. So that automatically assumes no symptoms, because if you got symptoms, get checked out as soon as the symptoms start, talk to someone. But average risk, no family history, no symptoms, 45 is the new number. It used to be 50 for some people, 45 for other people. But if you have no family history, no symptoms, you're otherwise going about life happy, healthy, regardless of what your diet, exercise pattern is, 45 is when you get checked out. When we start to introduce some of the other historical factors, like what your family history is, or if you don't know your family history, some of our patients are adopted and they really have no access to any part of their family tree branch. We would say, well, if you have someone in your family who's had colon cancer before, especially those first degree relatives to you, or multiple second degree relatives, or you're not 100% sure and there's not a good way for you to find out, we'll start you a little bit earlier. So if you had family members who were older when they got colon cancer, over 60, we'll start you at 40 as opposed to 45. But if you had a parent who had colon cancer, let's say, and they were 50, or they were, let's say they were 40 when they got diagnosed, their children or their siblings should really start screening at age 30. So 10 years before, whenever that relative who got diagnosed with colon cancer at a young age got their diagnosis. And that's all based off the principle that polyps, most cancers start off as a polyp. So a polyp is not cancer. If you let it grow, it turns into colon cancer. So if we had a time machine on that relative who had colon cancer and we went back 10 years in time, we'd probably find a polyp at that spot where eventually their colon cancer came to be. So in their relatives, we say, well, we don't have a time machine yet, but we could start earlier in you. So that way, if you do make polyps, we catch them in those much earlier stages where we remove them and they can never become colon cancer.
All right. Thank you very much for that explanation. So 45 for the healthy person, average risk. It could vary depending on your family history and other factors.
For sure.
Let's talk about going back to what you were mentioning earlier about different groups of people and that higher risk. So it sounds like family history is definitely a factor, but can you talk about the groups of people who are at higher risk than others? And can you also talk about why colon cancer is occurring at a more increasing rate among younger adults, which our viewers may have experienced personally in their family or have heard about it? Can you talk about that a little bit?
Yeah. So, we talked about family history and how that number is fluid depending on what the exact family history is, which relative, what age was the diagnosis. Other groups separate from the genetic syndrome. So if your family tree has a lot of cancers and there's certain patterns to which cancers and which relatives and so forth. So at some point, some families do say, hey, these things are coming up so often, we're actually going to go talk to someone who can maybe test our genetics, right? To actually do some sort of formal evaluation of our family history and decide, is genetic testing needed? And if they undergo that genetic testing and it says, hey, your family tree, your genetics actually do have genes that don't work the way that we expect them to, that really increases your risk of colon cancer. And Dr. Kant's going to talk a little bit more about that. So I'm going to put that group to the side, because those groups, I should say, because not every genetic syndrome is the same, they have really special recommendations, not only on what age they start, how often they have to come back for multiple tests, they get other screening outside of colon cancer and certain syndromes. So they're like a separate area. So we have the family risk people who don't have a known genetic issue. It's just colon cancer seems to pop up maybe a little bit more often than the average family tree. Then I think the next biggest group that's at highest risk, and this would include more younger people, are people who have either a disease called ulcerative colitis or Crohn's disease, especially Crohn's disease of their colon. And we know that these inflammatory conditions of the colon can increase the risk for cancer. And it kind of changes the way cancer develops in the colon so that it can occur at younger ages. It can occur more often. And it can grow more quickly. And so those people, when they get diagnosed with their ulcerative colitis or Crohn's disease, in addition to managing their inflammation, which will then hopefully lower their risk for cancer, they're going to get colonoscopies at younger ages and more often, sometimes as frequently as every 1 to 2 years, because we know that the way their colon grows and develops and in response to that inflammation may change how quickly polyps and dysplasia is the other word we use for it. Those lesions can form in the colon. So those would be the two main groups I would think of outside the genetic conditions: family history without a genetic mutation that we know of, and those inflammatory bowel patients would be at those higher risks. As for the last part of your question, there's a lot of theories as to why in general across the population, the younger people seem to be the one group where data says that cases and outcomes related to colon cancer are moving in the opposite direction. So there was a paper published very recently that said, like in the 60s, 70s, 80 age group, 50, 60, 70, 80s, incidence, deaths from colon cancer are all going down. That's the whole goal of all this. That's all great news. In younger people, it's still a rare event, but incidence went up. And the answer to why that's happening is, I think the end answer right now is we don't know exactly why, but that was part of what moved us to bring screening down a little bit from 50 to 45, is that, hey, there's some trend. There is a trend we've acknowledged. What exact factor? Is it diet? Is it something environmental in general? Is it something we haven't even thought to investigate yet that's causing it? Whatever it is, let's start to look a little bit earlier so we can catch some of these things either in the precancer state or the earliest stages where things like surgery are curative.
Thank you very much for that. How much does diet and exercise play into your risk for colon cancer?
I think it's variable now to the point where we can't just recommend one diet and be like, you'll never get colon cancer, right? So there's good studies that say it. The more processed meat we eat, red meat, lack of fiber, so not enough fruits and vegetables, seem to increase the rates of people who are developing polyps, and more polyps may lead to more cancer. Like anything in our body, what we put into it impacts our global health. So I think that an exact number in terms of risk, in terms of percentage of increase and things like that is hard to put down, but we do see trends that if your diet is really high in some things like red meat, processed meats especially, and really low in others, fruits, vegetables, sources of fiber, you might be increasing your risk. So the more variety you can incorporate into your diet, the more fruits and vegetables you can include, making red meat and processed meats, are more of a rarity or a special treat as opposed to a mainstay of your diet, are probably good things that every one of us can do in day-to-day life to potentially improve our chances of polyps and cancer.
Great, thank you very much. We're going to talk more about genetic counseling next. Dr. Kant, I'm going to switch over to you and talk about how genetics plays a role in the risk. Can you talk about, expand on what we've been discussing so far about genetics? How does that part play a risk in developing colon cancer?
Absolutely. So like Dr. Nosarin and Dr. Jennings kind of highlighted, you could be having a higher risk of, colon cancer based on family history. So that's one of the factors we look at. The younger you are, their suspicion of having a genetic cause is higher. So if we just look at the data, so young patients, so young onset colon cancer, when we say young onset, it's less than age 50. So in that data, that group, whoever had cancer, 1 out of 5 will have a genetic mutation, genetic alteration that would explain their cancer. We still don't know the 4, what's causing that, but 1 out of 5 we can still explain. And that's what where the genetics has the biggest role. Of course, anyone can have genetic testing. So around 10%, 10 to maybe 20% in younger patients less than age 50, where we can explain a genetic cause, a known genetic cause that I can test your blood for a genetic alteration, and that will explain why somebody got colon cancer. But it's not the biggest group, but it is a pretty significant group because you can find an answer in some sense what caused the colon cancer, but also increases your other organ risk, which can be increased from that, say, specific gene variation. We can screen for that. And then we put you on a screening for more frequent surveillance, not only for colon, for other organs, and then it affects your family members. So in general, 10 to 20% we can explain in the GI world by genetics. And genetic counseling is the first step. And the first step to know like who should get it is like earlier Dr. Nosri and Dr. Jennings mentioned family history. If you have family history of colon cancer, but if you have more than one family member with colon cancer, that's a kind of a red flag. Or if you have young onset colon cancer or other GI cancers, that could be something to think about and say like, oh, is this like sporadic? And maybe not. It could be something genetic that you can pass it on. A lot of time you can, if somebody is carrying a gene variation, gene mutation, there's 50% of risk passing it to the next generation. So if you have 5 kids, all the kids could have 50% risk of having a gene mutation. So it's something to think about and talk to your family members and explore a little bit more, like if you have family members. I also want to point out one thing, that you may not have colon cancer gene variation. Like somebody has a family history of other organ cancer, but you may still have a gene mutation that increases your risk of colon cancer. So even though nobody has colon cancer in your family, but you hear that I have an aunt with ovarian cancer, somebody with uterine cancer, somebody else with some other cancer, they could still be at a risk for increased risk of colon cancer. It's just that no one has developed that. And that is something you can only recognize once you have a good family history.
That's very good to know. Thank you very much. Can you talk about the program at MedStar Health, the genetic counseling program, and how specifically the gastrointestinal cancer prevention clinic at MedStar Georgetown helps patients who are at high risk?
Absolutely. So I work very closely with the Lombardi genetic counseling program. So they have a dedicated genetic counseling programs. They have genetic counselors where they see patients who are at a high risk or have personal history of cancer. And it could be GI or non-GI. That's a dedicated program. And if anyone is interested in contacting genetic counseling, they should contact Lombardi Cancer Center Genetic Counseling Program and able to pursue that. Say you have certain family history, should you be seeing them? That's one thing. One other thing is, of course, go through your primary care physician and find the correct kind of contact, but that's a dedicated program. The clinic I run is a GI cancer prevention clinic where I see patients who are at high risk for GI cancer. And like earlier mentioned, that you may or may not have cancer, but you could have a high risk. So we see these patients talk about what gene mutation they may be carrying or have a family history and how they should be evaluated. So it's a dedicated space for these patients. So there are certain conditions like Dr. Jennings mentioned earlier, Lynch syndrome. It's a condition that increases your risk for colon cancer, but 10 other cancer as well. Colon is highest, but you could have risk for ovarian cancer, uterine cancer, so many other cancers. And a lot of time we won't know if you don't know the family history, or unfortunately we get to know if somebody gets cancer. Those kind of patients I see on a regular and on annual basis because things change so much with family history or something new recommendation comes up. So this is what the clinic does. We keep an eye on not only on their GI kind of preventions, because of course I can do endoscopy and colonoscopy, but I also review globally like what other cancer risks they are at and are they getting the screening for that or not. So this is done more on a yearly basis or more frequently if needed. The world of genetics is changing very rapidly. We are finding new genes. I would say every 2 to 3 years, we find a new gene that is associated. So updating patients about these and letting them know, even research studies, like they talk about Lynch vaccine trials coming out and things like that. So that would be highly beneficial if they're attached to this clinic. So that's the goal of this clinic, to give a space and time to these patients at one place where they can see me for like kind of all surveillance.
Thank you very much for explaining that. So you talked a little bit about the process in your previous answer, getting screened, having conversations. You mentioned a blood test, but can you talk through the process from start to finish for genetic counseling?
Absolutely. So genetic counseling, if you're going to a cancer center, you contact the genetic counseling program, you usually will have a visit with the genetic counselor. A lot of time these days, these are virtual visits. They go over your family history, they calculate your risk, and then decide if you qualify for testing or not. Of course, there are models and other things we look at where we see if you truly qualify or not. So if you have just one family member, a third degree relative, you may or may not even qualify for genetic testing. But that's the first step for the genetic counseling. And usually once they see the genetic counselor, they get, say, genetic testing pursued. That result takes a few weeks to come back, and then they're recontacted based on the results. And then depending on what genetic variation was found or not found, they are referred to different providers. So that's the scheme for genetic counseling. In my clinic, I also order genetic testing. So I follow kind of the same process. So I do see patients who can have family history of cancer, and I send the genetic testing. I do the same thing. I recontact patient once I get the results, and we sit down again and talk about it if there's anything positive, which we need to follow, or anything concerning we need to follow. So that's the process. So the first thing is, if you're concerned, I would say contact our division, and get in touch, get an appointment. We do an evaluation, talk about in detail, also talk about what genetic testing means, the process, where to get the blood draw done, all that. And then we explain like outcomes and other things related to that. So that's the usual stuff.
Okay, great. So it sounds like it's very comprehensive between discussions and testing that you have with your physician. Can you talk about the types of genetic syndromes that put someone at higher risk for colon cancer?
Absolutely. So I would highlight Lynch syndrome here again, and you've heard this term a few times now. And the reason I highlight this is one of the most common inherited syndrome. And when I say most common, it could be 1 in 300 person. So that is how common Lynch syndrome would be. 90% of Lynch syndrome carriers do not even know they have this condition. And this is a condition that you can only find if you have a suspicious family history, or if somebody has personal history of cancer and do the gene testing and you find it. A lot of time you're not aware. So this is the most common, I would say, still underdiagnosed. And the goal now is to find and identify these patients, because if you find them, like Dr. Jennings mentioned, we start at age 45 for everyone. But if somebody had gene mutation, you may not have cancer at age 40, 45, but if you have this Lynch syndrome, we start screening you with colonoscopy by age 20. So it could be as early as 20. There are some other rare syndromes, I call it rare because they are rare, but they are quite dramatic in presentation, with loss of polyps. Familial adenomatous polyposis is one of them. Lots of other polyposis condition. Rare, but when they present, we have a chance to test the family members and start screening early. And sometimes in FAP patient, we start screening by age 10. So it's knowing who could have this syndrome. Lynch syndrome, I also want to point out, it's not a condition where you have lots of polyps. So as a gastroenterologist, if I screen somebody and I find 2 polyps, I cannot tell you if it's Lynch syndrome or not, unless and until I have a high suspicion based on your family history or any history of cancer in family or personal history. So it can be tricky. That's why identifying this condition is huge, along with many other rare syndromes, which usually have long names like Peutz-Jeghers syndrome and juvenile polyposis syndrome, etc. But the most common is like if you have multiple family members with cancer, especially if they're early onset, less than age 50, think about it could be something genetic.
Okay, thank you. Dr. Jennings, do you have something to add?
Yeah, I just think for our listeners, especially, there's a lot of commercially available things. We're talking about genetic testing, and there's a trend now where people can find out things about their genetics commercially. And I hope from listening to Dr. Kanth, you realize how complicated and specific all this stuff is, that the decisions to get those tests done and the specific type of tests are not necessarily something that's as readily available or easy to comprehend as these over-the-counter, at-home kits. And those kits, they can provide information, but they can also provide information that makes the picture really cloudy. And it makes it really hard to interpret when not done in the right context of all that information Dr. Kanth just shared with you, right? Like, she has spent her career becoming an expert in this one small area of the bigger medicine and gastroenterology world. And our genetic counselors have committed all of their time to that too. And it's just not, it's something to be aware of. Like, we don't necessarily want everyone to run out and do a home test and then come in with the 40-page printout of all the different results, because there could be a lot of stuff in there that doesn't clinically mean anything, but could make people really nervous too. So I think it's an important caveat that it's, all this discussion is really most powerful and most useful in the hands of an expert like Dr. Kant and the experts of our genetics counselors who can help really put everything in the right context.
That is a great point. Go ahead,
I
Dr.
just want
Kant.
to point out, this is a great point in terms of direct consumer genetic testing I've seen. I cannot tell you how many patients have had these kind of testing and they've never really seen a genetic counselor and they are confused. They don't know what to do. And this is really important because you don't want to underscreen, but you don't want to overscreen. You don't want to remove organs based on something that was not well understood and well explained. So I've seen this many times happen. So thank you, Dr. Jennings, for bringing that up, because this is very, very important. Have a good expert, genetic counseling team or expert centers where we have clinic like this to discuss and talk about, why we are doing what we are doing.
I mean, in the GI professional world, like I'm a gastroenterologist. Just last week, I came to Dr. Kant's office and I said, I have this patient and this is what you do all the time. And I think I can help him, but I think you could help him even more. And we so that just goes to show you that this is not just to the general population. Like I shouldn't go and just randomly order up whatever genetic tests I want on myself without understanding the repercussions of it, because it's could have really good information. It can be really anxiety inducing until you get to talk with someone who can really explain it. And it can lead to a lot of testing you don't need. So it's, there's roles for things like that, but it's always best when you have someone who can lead you through it.
Yeah. Speaking of at-home tests, we actually have a question from our audience about at-home tests. And I don't know if genetic testing is included in this, but the question was about ColorGuard. What are your thoughts on ColorGuard and is this effective? Dr. Jennings, I'll start with you.
ColorGuard is a
ColorGuard,
it's a stool-based test. So a kit comes to your home, they ask you to collect a stool sample, send it back, and then that test, they look for things like microscopic evidence of blood. So again, if someone had seen blood in their stool, that's a symptom, not screening, right? So it's taking what we think is an overall normal stool. It's going to look for microscopic blood in the stool, as well as DNA and protein that is thought to be associated with either cancer or polyps. So we're kind of looking for breadcrumbs in the stool that suggest that there's something in the colon worth going to take a look at. So in people who are average risk, no family history, could have gotten either their colonoscopy and get that done every 10 years, or they can opt for one of these tests, a stool-based test. And if that test is negative, the ColorGuard test says repeat it again in 3 years. If it's positive, you need a colonoscopy, because the ColorGuard doesn't tell you, do you have polyps or cancer? It just says there's some evidence of something in this stool that makes it worthwhile for us to do a colonoscopy in this patient. Those tests have benefit, especially in patients who have access issues to colonoscopy. We're getting a colonoscopy. There are parts of our country where getting access to a gastroenterologist to do your colonoscopy is not as easy as it is in Washington, D.C., where the whole city is barely 10 by 10 miles around the borders in our surrounding area. So in those situations, stool-based testing is a good alternative. ColorGuard is currently recommended as a second line agent compared to either colonoscopy or the other stool-based test, which is called FIT testing. FIT testing looks for microscopic blood. It's done annually. So the best screening test for average risk people for me is the one that you'll do and the one that you'll follow up on. So if I talk to a patient and they say, I'm never doing a colonoscopy, don't want to do it unless there's a real good reason for it, I will talk to them about something like ColorGuard. ColorGuard obviously has a lot of commercial, so people know about it and ask about it up front. So I just tell them that, if this is positive, you're going to need a colonoscopy anyway, but it is an option for screening.
Okay. Thank you, Dr. Serena. You have some thoughts on that?
Yeah, I was just going to add, with all the stool testing, we'll talk more about that. There can be false positives and false negatives. So if you get a negative ColorGuard, it does not mean that you necessarily don't have colon cancer or that you don't have a large polyp. Because again, that specific study or that specific test is looking for either blood or genetic markers that can be linked to cancer. But with things like such as a colonoscopy, where you can go inside and see a polyp and potentially remove it and prevent it from developing into colon cancer. So that's why, generally speaking, a colonoscopy is preferred over a stool testing if you're able to get it done.
Okay, thank you very much. Appreciate that. And thank you for your question. If you have other questions, please ask them in the comments. And just a reminder, we are talking today about colon cancer prevention with our gastroenterologists from MedStar Georgetown University Hospital, Dr. Kanth, Dr. Nocerino, and Dr. Jennings. We've talked a lot about what colon cancer is, risks, signs and symptoms, and the genetic counseling and testing. So we're going to shift gears and talk more about next steps after these tests are done, talk more about screening. But if you haven't done so already, give us a like, let us know you're watching, share this with your friends, and a reminder to ask questions in the comments. So Dr. Kanth, I'm going to go back to you, and I want to talk about next steps for genetic counseling. If someone, if there is a gene mutation that comes back after the genetic test is conducted, what are the next steps for patients?
Absolutely. So if something comes back that is concerning, that could be causing the risk, either increases your risk of cancer or can explain the cancer in family members, we have recommended guidelines based on any genetic mutation we are checking for. So based on that, we start screening, which is usually very early. So give you an example of Lynch syndrome, and there are hundreds of genes like this, but giving you an example of Lynch syndrome is caused by 4 major genes. And if any of these are positive and you have Lynch syndrome, we start many screenings early on. So we start colonoscopy. So we sit down, we talk about, okay, these are the other screenings you'll need, including starting early colonoscopy, endoscopy, but you need surveillance for uterine cancer. At some point, you may even consider removing uterus for these conditions. So there are a lot of implications. We send them to dermatologists to get a skin exam. We sometimes send them to urologists or do other screening, like for pancreas. That's another cohort of patients we have. We have increased risk of pancreatic cancer. So really it comes down to what gene variation we found, what other cancer it has been associated. So like I said, many genes are associated with more than one cancer. It cannot always explain just one cancer. It has association for other organs. And that's where the benefit of screening is. We know it, now we can screen you earlier, and hopefully we can find things earlier or prevent it. You'll never have colon cancer if we keep you on screening or other cancer. The hope is we can truly prevent, and we have seen that if we keep you on screening, there is a dramatic decrease in cancer incidence in such patients. But knowing is the key. If we know that, we can surely act upon it.
Thank you very much. And so we talked a lot about what the benefits and what patients can understand through genetic counseling and genetic testing. Can you talk about, or can you share with our viewers, why do you feel it's so important for our viewers to think about their genetics in order to help them understand their risk to prevent colon cancer?
Absolutely. So the knowing is key. If you know, you can prevent. That's the whole point, is early detection prevention. That's the key of knowing it. So all of us, if we don't have a known genetic mutation, family history, we have 5% risk of, say, colon cancer. If you have a gene mutation, your risk can increase anywhere from 10% to 100%. So if you know you are carrying a gene mutation, you can act upon it and start screening and prevention. So you could be completely healthy, no symptoms, no cancer, but you could still be carrying this gene mutation that increases your risk. So that's the part, like knowing if you could have that based on suspicious family history would be the key to for the prevention aspect. And because what we are doing really is hoping that even though you have risk of 70% maybe of developing colon cancer and Lynch syndrome, if we start surveillance, we can find these polyps, like Dr. Jennings mentioned. It's in the smaller, it's a small size, we can remove it, and it will never turn into cancer. So we do more frequent surveillance. So say, for example, an average risk who doesn't have a gene mutation, if they don't have a family history, we can screen them every 10 years. But in Lynch syndrome patient, we screen them every 1 to 2 years. And the reason is cancer can develop very quickly. So we bring them sooner so that before the cancer comes up, a polyp comes up, or if the polyp is still small, we can remove them and really truly prevent. So that's the idea of knowing what you may have that increases your risk of not only colon, but other cancer, and start early screening to prevent.
Thank you very much. And we talked about the family history part and a little bit earlier, and I think we mentioned a couple times, if someone does not know their family history, what do you recommend for them? Because there's still genetic testing. You can look and see what their genetics say, but what do you talk with your patients about if they come in and say, I don't know my family history?
Yeah, and if they don't know their family history and they still want to know, we can pursue genetic testing. A lot of time, I also want to mention this, that genetic testing is now very affordable compared to thousands of dollars patients have to pay. Now it's most of the time is, say your insurance cannot cover, or we don't have a like you don't qualify for testing because you don't know the history. You would maybe pay only $300 or less. So it's become more affordable. We can still pursue genetic testing based on like whether you know or not, but and that can, I would say, can be pursued for anyone. Essentially, having a family history would make things easier and maybe more high yield as well.
Okay. Thank you very much. Appreciate that. Let's talk more about screenings. I'm going to turn now to Dr. Nocerino. Let's talk a little bit more about screenings for colon cancer. How can our viewers know if they need to get screened? We talked a little bit earlier about age, and we talked about symptoms. Can you talk about that again and share with our viewers, when will they know they need to get screened?
Yeah. So we recommend that most people begin having colon cancer screening at the age of 5. So this is for the average risk person, no family history. And again, we recommend this in even patients who are asymptomatic. And again, that's because you may not feel that you have a little polyp inside your colon. So everyone at the age of 45 who's average risk should have some sort of discussion with their primary care doctor and gastroenterologist about colon cancer screening to know what options are available. People who have increased risk of colon cancer, like we discussed, strong family history, a genetic predisposition, or inflammatory bowel disease, they may begin screening at a younger age. And then in general, most people can stop being screened around the age of 75 or at the latest 85. But really, the most important thing is to have a discussion with your doctor to figure out what's most appropriate for you.
All right, thank you very much. What are the screening options that are available?
Yeah, so we talked about some of them briefly, but let's start with the colonoscopy. So this is our gold standard for colon cancer screening. And what a colonoscopy is, it's a procedure that's done often while a patient is sedated or asleep through anesthesia. We take a tube with a camera and look inside the entire colon. And what we're looking for are those little polyps or benign growths. If we see those polyps, we remove it at the time of the colonoscopy. It's important to say that in order for us to see inside the colon, a bowel prep is done prior to a colonoscopy, in which a patient drinks a lot of laxatives to have diarrhea to clear out their stool, so that when we go inside, we can see with the camera and we can visualize the entire colon. Generally, a colonoscopy is offered every 10 years, but it may be more frequent depending on risk factors or if you had polyps. So if you had a colonoscopy and multiple polyps were found, then you're predisposed to developing polyps again in the future, so you should come back more often. So that's the colonoscopy. Other testing that is available is something called a flexible sigmoidoscopy. This is done every 5 years. It's similar to a colonoscopy, but the main difference is that this test only looks at the last part of the colon, while the colonoscopy instead looks through the entire colon. The bowel cleansing is not as extensive as a colonoscopy. It's usually enemas because we're just, again, looking at the end of the colon. And oftentimes this procedure can be done unsedated without anesthesia. But a drawback to this test is that it obviously can't detect polyps or cancers or masses in parts of the colon that we can't visualize. So we're not sure, we can only really look at the rectum or the end of the colon and the sigmoid. So we're not looking again at the entire colon. Another option for colon cancer screening is called a CT colonography, also known as a virtual colonoscopy, and this can be offered every 5 years. It's the same preparation actually as a colonoscopy, including the bowel cleanse to get all the stool out. But instead of going in with the tube and the camera, we use CAT scan to look at the colon and take images. If polyps, however, are seen on this virtual colonoscopy, you then have to follow up later with your gastroenterologist for a colonoscopy and go through a bowel cleanse again so that those polyps can be removed. Potentially another drawback is that this CT colonography, you are exposed to radiation.
Okay.
Then we have stool testing, and we briefly discussed this. There's two different types of stool testing. One is looking for blood in the stool, and this is done on an annual basis. So the thought is that some large polyps or cancer may bleed. So if you do a test around the time that that polyp or cancer is bleeding, that test will be positive. And the test may even find microscopic amounts of blood in the stool that you may not actually see with your naked eye. But what I will say is if this test is positive, then you will need to follow up with a colonoscopy to further investigate and to see why there is blood in your stool. And then the other stool test we talked about is the stool DNA testing, or the Cologuard, which is often done every 3 years. So this stool test looks for blood in the stool as well as genetic markers that can be linked with colon cancer. It's a stool test, so it doesn't involve a bowel cleanse like the colonoscopy. But again, this screening test, if it's positive, you will need a colonoscopy. But in general, like we discussed, there are with stool tests, there can be false positives, false negatives. The stool test may not detect small polyps, which if we did a colonoscopy and we saw these small polyps, we would remove to help prevent colon cancer. So there's risk and benefits with all the different options out there. But it's just important really to talk with your doctor to figure out what test is best for you. But honestly, just screening somehow is, no matter how you do it, is what's important, just to have this discussion.
That is great. Thank you. Can you talk a little bit about the prep for colonoscopy? I know I've heard from just my own personal experience that is the most painful part of the entire process. Can you talk a little bit about that? What's involved?
What I will say is that I feel like the prep years and years ago were, very large volume, tasted terrible. So people did not like it. What I will say now is the prep that we most commonly use at Georgetown is Miralax prep. So as you know, Miralax, it's a powder laxative you can buy over the counter. It doesn't taste like anything. So you mix that with water or Gatorade. So it tastes like you're just drinking that water or Gatorade. So it doesn't have as bad of a taste. And then instead of, chugging a large, sometimes 4 liters, it's actually 2 liters. And what we do is what's called a split prep. So instead of drinking all at once, you're drinking half of it the afternoon before your procedure and the second half about 6 hours before. So again, it's a little lower volume. You're not drinking as much. It doesn't taste as bad. So people tolerate it better. And there's also multiple different types of laxatives and different preps out there. This is just one of them. And we can talk and figure out what you would feel most comfortable taking. And so most patients, for the most part, tolerate it, and you can think of it as a cleanse. But for, it's really important to clean out well, because when we go inside, we want to see everything. So that's why the laxative prep is very, very important.
Thank you very much. That sounds much better than what I thought to be the prep. So thank you for answering that question and sharing that with our viewers. So you talked about different screening options. Can you share which of those would require going under anesthesia and which are not? So if any of our viewers are concerned about anesthesia, what would their options be out of the ones you mentioned?
Yeah, so absolutely. So colonoscopy, I would say for the most part, we do use anesthesia, but there are cases where if a patient does not want to get anesthesia, you can do a colonoscopy unsedated. But what I will say is that it may be a little uncomfortable, right? We use a lot of air to inflate the colon and we're pushing the tube through tight turns. So for the most part, it's a more pleasant experience if you get anesthesia, but talk to your gastroenterologist. And if you don't want anesthesia, it is an option to do a colonoscopy unsedated. That flexible sigmoidoscopy where we just take the camera and looking at the end of the colon, that can also be unsedated without anesthesia. And then of course, the CT colonography, the virtual colonoscopy, that does not require anesthesia, as well as the stool test. So a lot of people do have concerns about anesthesia. So it's just important to bring that up with your gastroenterologist and to find something that you're comfortable doing.
All right, thank you very much. Really appreciate that. So we talked about the different screening options. We specifically, thanks for Dr. Nocerino talking about colonoscopy, which is the main screening option that we use and who should receive a colonoscopy. And you also talked about the procedure itself and whether if polyps are found, you mentioned those can be removed at the same time. You mentioned the small polyps. Is it any polyp that you see throughout a colonoscopy? They can be removed any size?
Yeah, so that's a good question. And, for the most part, we have lots of different tools that we can remove most polyps while it's done during a colonoscopy. And of course, some rare cases, if it's a very large, complex, polyp, sometimes you would have to come back, but for the most part, it can all be removed that same day. So that's what's great about a colonoscopy is you're taking a look and you're intervening that same day, unlike some of the other testing.
All right, thank you very much. And one more screening question for you, Dr. Nocerino. Is one screening more effective than others?
Yeah, that's a good question. Like we said, no matter what screening test you do, that's the most important thing is to do screening. But our colonoscopy is our gold standard. And the reason for that is because we're looking at the entire colon and we're looking for these little polyps. And we're able to remove them at that time to prevent it from growing into colon cancer. The other testing, like stool testing, it may not be positive if you have a small polyp. So, that's why the colonoscopy is preferred if you're able to do it over some of these other testing.
All right. Thank you so much. Really appreciate all that wonderful information. I have a question for you, Dr. Jennings. Now, I want to talk about the experience when you come to see a gastroenterologist. What our users or our patients expect?
Sure. So we often started off with a routine clinic visit to get to know one another. We get to answer your questions about, obviously if they're having symptoms, why their symptoms there. But let's just talk about a patient who wants to do colon cancer screening because that's what we're focusing on, right? So during that visit, we get to explain to them kind of what we did here today. What are their options? What are the pros? What are their cons? Is there anything in their family history or their history that tells us one test maybe is eligible to the general population, but would not be a good option for them, right? So we've talked a lot about family history. When you have a family history of colon cancer, colonoscopy is the test you should get. Like that recommendation is much more strongly put across to the patient versus someone who's average risk where, yes, colonoscopy still might be the best test we have, but stool-based test could be appropriate for you as well. So you have that option to you. So we get to go into a nuanced discussion based on each patient. We talk about the risk and benefits. We go over the logistics of this is what the day before is going to be like. This is what the bowel prep medicine is going to be like. And we give them all that instruction. So then the follow-up to that clinic visit is usually the time of their procedure, right? So they've made their appointment. They got all their instructions. We answer all their questions. They go home. Now, the week before their procedure, they're doing a little things in their diet, like eating a little bit less fibrous food. I know we talked about how a high fiber diet is great for you. That's still true. But in the week before your colonoscopy, it's not the best thing for you because that fiber tends to stick in your body and exert its good benefit in that way. We want to make things easy to clean out, like Dr. Nocerino was talking to you about with the bowel prep. So we've told them that week before they're going to change their diet mildly to avoid certain foods, maybe cut back on things. And then the day before is a really different diet where they've been fasting and they do the bowel prep and they come in. So when they come in to see us on the day of their procedure, they're going to meet a few extra people in addition to their gastroenterologist. So they're going to meet our nursing staff who's going to help them get changed into a hospital gown, put in an IV, because that's how we're going to give you the medicine to keep you nice and comfortable, the anesthesia, so to speak, during your procedure. You're going to meet your anesthesiologist, the provider who's going to be in the room with you, monitoring you through that sedation, making sure your body gets just enough medicine so that you're comfortable and not feeling anything, but not too much that you would be more sleepy and things like that. They're going to make sure you're breathing well during the whole procedure, but the expectation is that you'll be breathing on your own the entire time. They're just there to monitor. So then once we get you all set up in the gown, we have our IV put in, you've talked to those people, the actual procedure itself, after we've given you the medicine to go to sleep, is about 20 to 30 minutes. So the actual time where the procedure is happening is about 20 to 30 minutes. When we're all done, the scope is out, any polyps that were in there were removed. We turn that medicine off, you start to wake back up, and then we actually talk to you in the recovery area. We go over the results of the test that very same day. As you're getting dressed again, and we give you some food, something to drink, eat and drink, because you haven't had anything to eat or drink that day since you've been waiting for your procedure. And then you're going to be able to go home. That day, because you've had anesthesia, we tell people for the rest of the day of that procedure, you might be a little bit groggy. It's a good day to catch up on sleep, be lazy, sit on the couch, watch some television, enjoy some food because you've been fat, you've been on fast for the last day or so. But the very next day after their procedure, they're back to normal. There's no recovery time. There's no, I can't go back to work for this long. I can't exercise. It's pretty much instantaneous recovery in that regards. And then about a week or two later, we follow up with them over the phone, through the patient portal via medstarhealth.org, or in a follow-up visit, if that's what the patient had requested and scheduled, to go over the results of what the polyps we took out looked like under the microscope. So that day you leave knowing, was there anything concerning? What should I be worried? But the final results come about a week later when we say, hey, we looked at all those polyps under the microscope. They're all benign, not cancerous. You're good to go. Come back in 5 years, 7 years, 3 years, whatever the appropriate recommendation was. So for that whole visit, the clinic visits 15 to 20 minutes, a couple of days, weeks before your procedure. The procedure visit is about a 2 to 3 hour visit, where the procedure itself is only about 30 to 40 minutes. And then that's something you may not have to do again for a number of years, depending on what we find in your family history.
All right. Thank you for that detailed explanation. Really appreciate it. I was following through in my head almost like I was a patient going through the process, and it seemed very straightforward, streamlined. You got everybody there for you, making sure that you're well taken care of, and it's a short recovery, or just that day. So that's great news. Thank you so much for that. Let's wrap up with one more question related to, we have a colon cancer risk assessment available. Dr. Kant, can you tell us a little bit about our free online colon cancer risk assessment that we offer?
Yes, so we do have a kind of an online version of knowing if you could qualify as a high-risk individual, and then you may consider seeing a genetic counselor, or actually more so to see if you qualify for screening for colon cancer. Everyone age 45 should get, but you could be at a higher risk for other reasons, like your family history of polyps or cancer. So this is a nice tool, and it is available online. If you go to medstarhealth.org and search for colon HRA health risk assessment, you can find this tool, and you put in your age, sex, then some history of family history, but it brings up and says you should talk to your primary care physician, or you should be getting a colonoscopy. That kind of like, okay, you should be thinking about screening. So it helps you a quick assessment in some sense within a couple of minutes to know whether you could be at risk. It doesn't give you all detailed genetic testing kind of insight. It is really to screen at first level, I would say, do you qualify for screening or not? And you could qualify for earlier screening based on some of the family history assessment is, but you can do it from anywhere online. You can check it and see if it shows that you should talk to your primary care doctor, or you should consider screening such as colonoscopy. Then I would highly encourage you to meet with your primary care physician and talk about this.
All right, thank you very much. I do have another question from our viewers that I want to ask, and also ask each of you as we wrap up if there's any final words, key takeaways you want to make sure that our viewers get out of this discussion today. So I'm going to start with you, Dr. Jennings, and I'll ask this audience question as well. The question's from Sam. How far out are we scheduling for colonoscopies? Can you answer that and also give us your key takeaways?
On average, it's about 2 to 3 months, so 8 to 12 weeks, depending on the indication for the procedure. So if you are having symptoms that are alarming, we are going to do everything we can to work with you to get that test done sooner rather than later. For screening purposes, that doesn't have an absolute date. Like the day you turn 45, it's okay to get your colonoscopy 6 months into your 45th year. It's okay to get it at the 360th day of your 45th year. It's okay. So we're going to try to find a date and a time that's convenient for you. But on average, the wait time is somewhere between that 1.5 to 3 months, depending on every provider's schedule and things like that. The benefit of working with MedStar Health Georgetown is specifically at Georgetown, you know, we have so many gastroenterologists that, and a busy endoscopy center, both here and at Lafayette, that we have so many different opportunities to fit you in. So again, especially in those patients who have symptoms or high level of concerns, that wait time can usually be shortened in most areas. So don't let thinking that it's going to take a month or two to get the procedure done stop you from reaching out and calling, because again, on case-by-case circumstances, we can often make that turnaround time a lot faster. And I think as parting messages is in that same vein, is the more we talk about this stuff without Facebook Live, at home with our families, if you've had a colonoscopy and it wasn't that bad of an experience, talking to your other family members about that, just letting them know that you had it done and it wasn't a big deal, it goes a long way to help people to feel comfortable to ask those questions and get it done. And then we have the opportunity then to possibly help prevent colon cancer in that person who otherwise would have never thought to call us and get their test done. So the patients and the people listening and the general people have as much power, if not more power, to help us get everyone screened like we want to in the United States and across the world for that matter.
That's great advice. Thank you very much. It's very important to share this information with our family and friends, especially those of us that are watching today, sharing this information, having those conversations, maybe on the 45th birthday of your family member, you can take that opportunity to remind them. So thank you for that, Dr. Jennings. Dr. Nocerino, would you like to go next? Give us your key takeaways.
Yeah, of course. So like we chatted about, most cases of colon cancer are preventable. So it's really important to get screened. And there's so many different types of screening options available. So meet with your gastroenterologist, talk about all the different testing. Even if you're asymptomatic, it's really important because we can prevent it.
Thank you. And Dr. Kant, what would you like to share with our viewers before we wrap up?
Absolutely. So I always say, know your family history. If there is any suspicion or if you have any concern that you could have, you could be at high risk for cancer. Like I said, you may not have colon cancer in your family, but if you have multiple family members with cancer, so talk to your primary care physician, talk with genetic counseling. Never a bad time to talk about whether you could be at risk. Absolutely.
Yep. It's a perfect time, like Dr. Jennings said, talk to your family members about this, and at the same time, ask them about their family history if you don't already know. So great takeaways. Thank you to all three of you for joining today. That is the end of our discussion. Thank you to our viewers for watching and asking your questions. If you'd like to request an appointment with one of our experts, or you would like more information, you can call us at 202-295-0570. Thanks again to everyone. We hope you have a great rest of the day. And remember to get screened. Thank you so much. Have a great day.
Thank you. Thank you.
Thank you.
Thank you.
Bye.